All right. Welcome to the 11th Medical Association Facebook Live. My name is Aruna Arora, president of the association. I'm here with our two wonderful guests. We have, of course, our state health officer, Dr. Scott Harris, and then we have our worldwide expert, our UABID Dr. Michael Saag, and we are here to discuss an update first, and then the confusing topic of mixing and matching of booster vaccinations. So, Dr. Harris, if you want to give us an update.
Sure, I would be glad to. Thanks very much for having me again, and thanks to all of you for joining. We've really enjoyed getting together with you on these Thursday calls, and we still have some more scheduled for the next few weeks as well. You'll hear more about that later in the broadcast today. From the standpoint of what we're seeing in Alabama, our numbers are headed the right direction, although, we certainly remain cautious. We still are a state that trails most of the country in terms of having people vaccinated, and that always feels a little bit ominous. And yet I would say it has been good to see that our hospitals are faring a little bit better now. We have between 400 and 500 inpatients around the state on any given day over the past several days. That's not a great number compared to back in the spring, or certainly back a little over a year ago, but certainly much better than we were seeing in August and in the first part of September, when we were approaching 3,000 people in hospitals around the state. We're having daily case numbers now of 300 to 400 people a day that are being reported to us. Again, that number is better, certainly could be improved, but it's better than what we've seen. We do know that there's a lot of testing going on that we may not be aware of. There's a lot of antigen testing being done in locations that doesn't necessarily get reported to us right away, or at all in some cases. So we're probably undercounting those numbers a little bit, but again, it's certainly better than when we were seeing 4,000 or 5,000 new cases a day being reported to us. So those are good things. One thing that is an unfortunate side effect, I guess, is that when numbers go down and people aren't hearing as much about people they know who are infected with SARS-CoV-2, we start seeing a decreased demand for vaccination. And unfortunately, our vaccination rates are starting to fall as these numbers are going down. There just doesn't seem to be the same urgency in some people's mind. Some people who were motivated to get vaccinated because they knew someone personally, maybe some of those people are still on the fence right now. Almost all the shots we're doing right now are booster shots. We're doing very few in terms of initiating a primary vaccination series. So we have now vaccinated more than 2.5 million people in the state with at least one shot. About 2.1 million have been fully vaccinated, and we still use as that definition of fully vaccinated completing that primary series. So that doesn't include booster shots. So about 2.1 million people have either received 2 shots of the mRNA products or one of the J&J products. So we are going to talk a lot today about boosters. I'm actually very excited to be on the call and hear Dr. Saag address that. It's a really interesting and sometimes confusing topic, and there's a lot still developing there in terms of what knowledge we have. So there are several things that we want to go over there. I will just mention one more quick thing, if I can, Dr. Arora. We have learned, fairly recently in the past few weeks that there is going to be an oral antiviral drug made by Merck called molnupiravir. We as in public health are going to be responsible for distributing that product in the same way that we've been responsible for distribution of, say, monoclonal antibodies or even vaccines originally, or back to PPE and testing. It's going to be yet another logistics project for us. This is going to be a pretty interesting calculation to figure out where to have this drug sent. It looks right now that it'll probably receive an EUA around or maybe slightly before the first week of December. It's a drug that's going to need to be given orally over a 5-day period. And so since you want these antivirals within the first 10 days of illness, it needs to be given to somebody within the first 5 days of symptom onset. Or recognition that they're infected, a positive test, I guess, if they're not symptomatic. So you're going to have a tight window for giving that drug. We're still awaiting guidance, but it's probably not going to be authorized for women who are pregnant. So patients of childbearing age are probably going to have a negative pregnancy test. So that really limits the number of places this drug is going to be available. It's going to be by a prescription. It's going to be within the first 5 days of illness. It's got to be someone who can get a COVID test confirmed and the results back, as well as a pregnancy test. So there's not going to be giant drive-through clinics handing out bottles of pills. It's really going to be one-on-one, face-to-face encounters, with practitioners. So we're still working through the logistics of that, and I'll let you know more about it. So that's really all I had, Dr. Arora. Thank you very much.
Thanks for that update. It's important to recognize that we do have the monoclonal antibodies in this oral pill, but our vaccination is really, key. And so we are going to segue into Dr. Saag, kind of dissecting some of the real complex information that I guess came out the third week of October. So Dr. Saag, if you want to.
Sure. Well, just to add to the molnupiravir story, Great Britain approved it today. So the movement is starting to happen worldwide. And I want to stress that notion that this is just like Tamiflu in a sense that you want to give it as early as possible. So it's from the day of onset of symptoms. So that's really important. So let's talk about boosters. And I think it's important to go back to some basics. We have these vaccines that were approved in a very rapid time. And some people get nervous about that and say, well, the studies weren't done well. Actually, the studies were done impeccably well. But the one thing that we didn't have that we normally have when a vaccine gets approved is longer term follow-up in terms of the durability of the efficacy or the effectiveness. And so what has been discovered over the last 8 to 10 months is that the immunity in the first several months after the initial series in immunocompetent, meaning normal host, is quite strong, but it starts to wane at about month 4 to 8. And so we see breakthrough infections starting. And in the United States, that coincided with the emergence of Delta. So initially, we weren't terribly clear on were these spikes in cases we started seeing in July, August, September, was that due simply to Delta not being quite as well neutralized by the immunity that the vaccines gave, or was it the immunity of the vaccine simply just wearing out? And some recent studies, one in Lancet that was quite well done, showed that it actually was just the waning immunity. The Delta variant was neutralized just as well as other variants as breakthroughs happened. So that was big news. That's really important in understanding how we should be thinking about the vaccines, that at least for Delta, and we don't know yet about Delta Plus, hopefully that stays away, but it does seem that the longevity of the first 2 shots of that initial series is around 4 to 6 months. And then it starts to wane in terms of its ability to protect against symptomatic infection. Now, backhanded good news is that it still protects really well, even for those who get symptomatic infection, against serious high-level morbidity from COVID, like hospitalization and for sure death. So still have some protection overall for that, but we're starting to lose out in terms of the breakthroughs. So what's been happening is that this recommendation for a booster is now made, especially for immunocompromised folks, and we started that several months ago, but now it's starting to apply to people over the age of 65, anyone over the age of 18 who has an underlying health condition, or those who otherwise we feel would benefit from this. But I think what we're going to find is that the immunity will be necessary to boost for almost everyone, and I suspect we'll be doing that in the next couple of months. So that's the background. Should I go forward with the mixing matching?
Yes. No, that's a perfect kind of, introduction into how we think about boosters and how, the Delta variant, I think you explained it really well. And the immediate concern that we had here in the United States at that particular time. But if you can kind of break down some
Sure.
of if you were to have completed your mRNA 2 doses and who's eligible and kind of, the options, from that NIH study, and of course, Europe.
So this NIH study is fantastic. It hasn't been quite through full peer review. It's been initially presented to us as a preprint. I actually read through it as if I were a reviewer just to find flaws or faults, but it's an incredibly well done study. What they did is they took individuals with normal immune systems, basically, and followed them out in terms of their ability to develop IgG antibody in the first place, but critically looking at neutralizing antibody, because that's kind of the functional equivalent of does this vaccine work, especially in my view of preventing symptomatic infection. And indeed, everything I just said was that after a period of time, that neutralization strength was waning at about 6 to 8 months. So then they took people who got either Janssen, the 1-shot, or Moderna, the 2-shot prime, or the Pfizer 2 shots, and then randomized those folks to receive either Janssen, Moderna, or Pfizer as a boost. So if you got Moderna, there's a 1 in 3 chance you would get Moderna again, et cetera, and so forth for all of them. And what was fascinating was that, let's just isolate Janssen out. If you got the J&J 1 shot, your immunity by the time the study was done was quite low. So I think I would put into the category of people who need a booster now is anyone who got 1 shot of Janssen, J&J, back in March or April. Now's the time to get the booster. And my personal view based on these data is that you should go ahead and get either Pfizer or Moderna. And to dig into the numbers a little bit, if you got Janssen and looking at neutralizing antibody only, you would see that you would only have about 8.9 international units per milliliter. You want that number above 20. So it had already dropped. For Pfizer and Moderna, Pfizer was 24.8, so just at the threshold. But Moderna, even out to the 6 months or 7 months, was at 88.7. But here's the cool part. If you got one of the other, let's say you got Janssen, J&J, and then you went forward with with another J&J, your neutralizing antibodies jumped about 600. But if you got original J&J and got Moderna, your number went to 901. And if you got Pfizer, it went to 785. So a much better response going from J&J to Moderna or Pfizer. So that's what I would recommend. So let's break it down in case, let's say you got Moderna as a first line therapy. Then what you're going to see is that the numbers went up to, again, about 700 or so for neutralizing antibody if you got Moderna again, and it bumped up to about 495 for Pfizer. The cool part of this is that we now know that you can mix and match. If you got Pfizer, if you got Pfizer originally, and then you got, I've got to scroll back and forth. Okay, if you got Pfizer and then you got Pfizer again, your number went from about 20 up to 216. If you got Pfizer and then got Moderna, then you went up to well over 380. So I think personally, I would mix and match based on this. And specifically, if I got J&J, I would go to Pfizer or Moderna. If I got Pfizer, I would get Moderna, but you want to make sure for this that you're going to get half dose, the 50 microgram Moderna, because that has fewer side effects with really good immunity. So you can sort of now streamline it to that. And if I got Moderna initially, I would probably go with Pfizer, although going with Moderna again at half dose would be okay. So summarizing, J&J, get your booster now, Pfizer or Moderna. You got Pfizer or Moderna initially, I would take the opposite, but make sure if you're going to get Moderna for your booster, half dose, 50 micrograms.
I think that really breaks it down very well. There's less confusion when you think about it that way. And I guess the fancy word for what you're in favor of is the heterologous, combination. And so the J&J folks for sure, is high priority to get their booster with an mRNA, like you just described so beautifully. And then just to go over maybe the categories, of people who are currently eligible for a booster.
Yeah. And Dr. Harris may want to, I don't have the full list, but I know that anyone who's over the age of 65,
Sure.
anyone who has underlying health conditions over the age of 18. And in my view, I would add to that, anyone who got J&J initially should get a booster now. Others you would add?
Yeah, that's almost complete. Yeah. So right now, anyone who's had J&J and is beyond 2 months from that J&J is authorized to receive a booster dose of whatever product, as Dr. Saag explained so well there. For people who initially got an mRNA product for their primary series, it's exactly what Dr. Saag said. It's people over 65, it's people over 18 with that list of certain chronic health conditions that we've talked about so much, which honestly affects a lot of people in Alabama. But then they also have included people over 18 who are just at high risk for exposure because of either their job or their living arrangements. So that might be a younger person who happens to be in a nursing home, or it might be a healthcare worker working in a hospital or nursing home. So those are people who might be younger and even, completely healthy, and yet because of their risk of exposure because of where they live and work, they recommend to get a booster too. And I would say that to me generates a question that we've spent a lot of time thinking about, but I'd love to hear Dr. Saag's thoughts on that. How would you, think about the young, healthy 40-year-old who got their, Moderna vaccine 6 or 7 months ago, who's not otherwise at risk? We at this point, they're not authorized to receive a booster. We know a lot of people are going out there and getting them. But what would you recommend? Should that person just wait a few months to see what the data shows, or how would you advise them?
Yeah, it is a gray zone. My instinct says to lean towards getting it, even though it's not authorized now. But I think if we're going to do this by the book, my bet is that by Christmas time, there will be approval for that to move forward, because the data are pretty overwhelming that this biologic activity that I described after the first 2 shots, you're going to see waning. What we don't know the answer to, and this we got something to look forward to in the future, is what about after you've had the initial 2 shots and then you get a booster? And let's say you're that exact person you described, Dr. Harris. Will they ever need a booster again? In other words, is that 2 + 1, 6 months, 8 months later? Is that enough? So for some diseases, it is. We used to give shingle shots that way and some other hepatitis series that way, and we don't ever think about it again. My personal view is that we'll probably need to give a boost, but maybe not except for annually. We'll see. I don't know how it's going to go. But the other question I get, Dr. Arora, is for someone exactly like what Dr. Harris said, well, should we check antibody and then make our decision based on that? My recommendation is not to get into that mess, because number one, the tests are not standardized. What I quoted to you were tests done at research laboratories with all kinds of controls and that type of thing, and commercially available antibody tests. Some of them are good, some of them aren't so good. And getting into that mess of trying to decide which antibody test you're going to ask for is a mess. And the second thing is, I gave you a general cut point of 20 international units per mil, but that was neutralizing antibody. And to my knowledge, almost all the commercial tests do not do that. And to me, that's what's important. Finally, then let's say you test it and it's okay. When do you test again? And you just get into this chasing your tail kind of thing. I would just go with whatever the recommendations are when they become available for that patient who Dr. Harris just described, 40 years old, healthy otherwise. I would just go ahead and give them the booster when it's indicated and move on.
Okay. Let me ask you this. Another question we get a lot, and I think you maybe covered it in what you were just saying. What if I'm a person who received my primary series and then I had a breakthrough infection a few months later, and maybe I'm healthy and doing fine and did okay with it? Do you think I still need a booster dose?
Well, I can't say for sure, but I probably would go ahead and do it, because I think the side effects, yes, I had COVID, as everyone knows by now. And then I got my primary series, and I had a pretty strong reaction where fever, chills, headache for about 24 hours. It wasn't pleasant, but it wasn't anything that put me in jeopardy or even thinking about hospitalization. And when I got my booster shot, same thing. So I think it's just a sign that the immune system is primed for a lot of people. But I would just go ahead and get it, because to distinguish that over time is going to become, again, quite challenging. One study that's really worth talking about, which I think hits right at home with local questions, is a study that was just published about a week or two ago that looked at people who had never had COVID before, and then asked the question, if they were vaccinated, how good is their immunity, versus someone who had COVID before and never got vaccinated. So a lot of people are saying, well, let's just wait for everybody to get infected, ignore the vaccines, they're not going to be worth it. And what was fascinating in that study that I just described, the people who had had COVID previously and never got vaccinated were 5-fold more likely to have a breakthrough infection than those people who had never had COVID and just got their primary series. So that's probably telling us that, yes, natural immunity from an infection does have some degree of protection, but it's not nearly as strong or as durable as a vaccine series itself. So I think that recommendation we've been saying all along is, if you had COVID, go ahead and get a vaccine anyway. I think that was good advice with these new data in retrospect, but also it gets to the question a little bit here of, I wouldn't start distinguishing between the two. I think it is fair to say that if you have had COVID before and then you get vaccinated, your immunity is going to be among the most robust that exists. So go ahead and get the vaccine.
Dr. Saag, I'm so glad that you brought that point up. I think it's really important to acknowledge the immunity and the natural immunity, but the boost of getting that additional vaccination. And certainly nobody would encourage someone to just want to catch COVID, because you still have the implications of long COVID that remain, that you could protect yourself from if you had vaccinated. So I really appreciate you stressing that particular study.
Could I just jump in and just add to that as well? And I've heard Dr. Saag say this many times. I mean, the other issue with waiting to get COVID is 1 out of 50 people are going to die, in this state anyway. Virtually no one dies from the vaccine. There have been some really rare situations, but at every age group, including all the way down to pediatric age groups where kids usually don't get severely ill, there's still a greater chance of serious illness and death from the vaccine, from the natural illness, than there is from the vaccine. The vaccine is always going to be safer in every age group than allowing yourself to be infected.
To put the numbers on that, among the deaths that we've had, and unfortunately we just crossed this horrible threshold of 750,000 people who have died in the United States from COVID over 20 months. There's a 10 to 12-fold higher risk of death per infection with COVID among those who are unvaccinated. That number, there's very few things in medicine that have anything in double-digit fold higher. This is one of those. So we're seeing, just you walk through the wards at any of the hospitals, especially in September, and you look in the ICU, and 95% of people in the ICU, 95% of people on ventilators, roughly 95+% of people who died from COVID were the unvaccinated. And that's just a fact. The other thing moving forward, and I want to underscore what Dr. Harris said earlier, that it's a little bit concerning that as the numbers are coming down, people are starting to step away from vaccination of their primary series because they say, oh, it's not around. My opinion is this virus is going to be with us for many years to come, maybe over a decade. And in that view, that means all of us at some point, if we're not vaccinated, are going to probably come down with this. This virus is going to find everyone that it can to infect over time. So it's better to be protected against that serious disease, puts you in the hospital, perhaps even takes your life, just by getting a vaccine. It is safe. And the deaths that people are talking about are simply things that were reported to the vaccine adverse event reporting system that our government has set up to follow any adverse event from a vaccine. And you always will have people who have just coincidentally passed away from some other problem, got hit by a car, whatever it is, that gets reported. And then we have folks who adjudicate that and say, what's the probability that this death was related to, caused by the vaccine? And I can't think of many cases that I've seen that were reported. The one instance where we know about for sure was back in April with J&J. Remember, they had those unusual clots that we talked about on this broadcast before. And there were, I think, 12 to maybe 20 people total who got those clots. Some died. But that's how that system worked. It was that system that picked up those unusual deaths. The system works. These vaccines are very safe, and we should be encouraging people to get them. And I know next week you're going to have Dr. Kimberlin on to talk about it for the 5 to 11-year-olds, but that's great news yesterday or day before that vaccine is now approved, 10 microgram dose of Pfizer. That's 1/3 the adult dose that's now approved and available for our kids. And my grandkids are going to be some of the first in line to get that.
It is definitely exciting news. And yes, we're excited to share that information next week. I think that having both of you on here and having Dr. Kimberlin on next week as a pediatric infectious disease doctor, having Dr. Jeannie Marazzo on the following week as an infectious disease doctor. I mean, I just can't reiterate how important it is when we are looking for information in a novel situation to truly go to experts. Dr. Saag, you know, I said it at the beginning, I forget it here and there because you're so down to earth and you're from, you played football, you went to Tulane, you can relate to anybody, but you're a worldwide expert in HIV. And it shouldn't be lost upon us when we look for information, we have to look to the experts in a field. It just can't be stressed, more because there are a lot of convincing anecdotal stories out there. And really and truly, when people are confused, when our patients are confused, there are a couple things to do. One, of course, talk to your doctor, your own doctor, because you have a personal, trusted relationship with that doctor. But secondly, make sure you trust your expert opinions. Make sure that those people are truly experts in their field. And so Dr. Harris, being the state health officer, you have an infectious disease background, you have a public health degree. I mean, these are truly the kind of backgrounds that we should be getting our expert opinion on for the matter COVID virus, right? And what to do in vaccinations. And so, as much as we're talking about the boosters, I guess Dr. Paul Offit had made a comment that really boosters wonderful, but the only way truly to get out of this is for all of us to remember that we need to primarily vaccinate, just like we do for a whole bunch of other diseases, and COVID should not be looked upon as different from that. Sorry, soapbox.
Thank you.
Any final comments before we kind of wrap it up today?
I would just say thanks. Let me reiterate what you said. We are really trying very hard to get people that primary series, those first shots, the first and second shot of an mRNA vaccine. We still have a long way to go. We've sort of edged above about 7 or 8 states now. That's great, but that's not that great. And so we still encourage everybody on this call, if you haven't gotten vaccinated yet, please consider talking to your own healthcare provider. Reach out to us on this call. Reach out to me. We have people in the public who do that every day, and we're happy to try to help you think through those issues. Obviously, if you have a primary care physician, that's the person who knows you best and is a person best suited to give you advice. But we think that everybody ought to be vaccinated. There's virtually no reason I can think of that you shouldn't be vaccinated with these products. And it's the way to protect yourself, to protect your own family and the loved ones around you. And it's a way to get us back to normal.
Yeah. I'll finish with this. This morning or all day today, we have the Center for AIDS Research national meeting, and it's being hosted by the University of Pennsylvania virtually on Zoom. Dr. Fauci gave the keynote address about 2 hours ago, and he reviewed the history of the platforms that created the mRNA vaccines, as well as the adenovirus vaccine, but also the work that had gone on for decades, looking at viral proteins and seeing which ones were immunogens. And the reason we could get through our vaccine so quickly with COVID was all that work had been done for 20 years, setting the foundation. And then he went through looking at some other viruses that use these platforms, and we still don't have vaccines against those pathogens, but we do have it against SARS-CoV-2. I think it was maybe even divine providence. I don't know. We are very lucky that these vaccines hit. And so what I'd like people to think about just in closing here is, what if, heaven forbid, we've developed these vaccines, but they didn't work? They didn't, like the AIDS vaccine or the respiratory syncytial virus vaccines and several others that we've been working on for a long time. Those vaccines haven't worked in terms of protection. These vaccines work in the 90% range, 95% range. That is a miracle. And ask yourself the question, what if the COVID vaccines had not worked? Where would we be today? Where would we be today if you're a healthcare worker or a first-line responder or just the public in general? If you're over the age of 65, the deaths have plummeted in that group because people got vaccinated. So it's really something we should embrace and champion, because it is a true miracle, and that it's getting us out of this horrible epidemic. But it's going to take all of us participating to put this in our rearview mirror for sure. Otherwise, we're going to continue with these pockets of outbreaks over the next 2 to 5 years for sure, and maybe for the next decade. This is our way out of this.
I think that you said it really well. You brought it up last year. I remember you said that, because this all came out in December, that this is a Christmas miracle. We're about to hit on holidays right now. Today's Diwali. We've got Hanukkah. We've got Christmas. We've got Thanksgiving. We had Halloween. So we've got lots of groups getting together, and we just really need to remember that the best way for us to gather and do what we do as social creatures, especially after 2 years of having hiatus and interacting as human beings, is to protect one another. I thank you both for your time.
Great. Thanks for having me back.
Absolutely.